Greetings from India, Agra, the city of Taj Mahal. I am Dr. Narendra Malhotra from Ujala Cygnus Rainbow Hospitals, Agra. It's indeed a pleasure to be a part of this workshop of AOFOG, the AOFOG conference. It's not a very happy feeling that I'm connected virtually. I mean, we definitely would have loved to be physically there, as we have been for all the AOFOG conferences till date. So I have been asked to talk on endometriosis evaluation by ultrasound. So we will talk on what the ultrasound features are, and we will talk about the International Endometrial Analysis Group, what they say about how we should be evaluating endometriosis. I have no disclosures, no conflict of interest in presenting this. And whatever machines I'm using, I'm not selling those. We are situated at a place called Agra, somewhere here in North India, where the Taj Mahal is, and this is our working place, and where we do a lot of international trainings in ultrasound, laparoscopy, and even IVF. So you all are most welcome to attend our training sessions online or on Zoom. Endometriosis. Endometriosis is a very complex, challenging, and elusive disease. And this is a painting in the Art Association by Judy, who depicted a woman in pain with endometriosis. Now, here's a clinical scenario. It affects 1 in almost 15 women, reproductive age group, cause not known, not clear how it can be prevented, not known how to predict the development of the disease, no simple test except surgery. Even on surgery, the diagnosis is sometimes an educated guess. There are 4 treatment options, none better than each other. Welcome to the world of endometriosis, which spreads about 25% in reproductive age group women all over the world. And not even only in reproductive age group, it is now seen in adolescent, perimenopausal women also. So making it very, very complex disease. Almost 1 in 10 women in the reproductive age group. And the worst part is 20% of them may be asymptomatic and the disease grows. About 15 to 45 present with pain, 50% infertility, and adolescent chronic pain, 25%, perimenopausal women, 50% with pain. So dysmenorrhea, dyspareunia, infertility. So endometriosis, we must turn over a new leaf. We must re-understand this disease and its solution, the medical, surgical, because pelvic pain, infertility, pelvic mass is what disturbs us. And I bring you greetings from our team, myself, Dr. Narendra Malhotra, Dr. Jaideep Malhotra, and our daughter, Dr. Niharika, for helping me make this presentation. We also look at the new practice guidelines of ESHRE by 2013. And before I go and say, see, when the adolescent comes, remember, endometriosis attacks the peritoneum first, then ovarian surface. In adults, it is peritoneum causing adhesions, ovary causing endometriomas, rectovaginal causing deep adenomyosis, which is the most difficult thing. And in perimenopausal, it attacks the ovaries first, causing endometriomas, and then the extra pelvis, so causing urinary obstruction, bowel symptoms, things like that. So endometriosis is detected in 30% of infertile women if we do a transvaginal scan. And 1/3 of them are endometriotic cysts, usually bilateral, often multiple. If unilateral, more common on the left side. Adhesions are very common, smooth, shaggy walls and areas, and punctate or linear bright echoes in the wall. Most consistent features of endometriosis by ultrasound is unilocular, maybe multilocular, low-level echoes, classical ground glass appearance in 95% cases, thick wall, there may be some nodularity, echogenic flex in the wall, lace-like patterns of the hemorrhagic cyst in 8% of them. So you see the pictures here, multiloculated, single ground glass, lace-like appearances. And this, you have to know the iota benign basic steps, pattern recognition which will classify all this. Then when we turn on the color, you see scattered vascularity at the ovarian hilus and regular separate peripheral vessels, which is characteristic. So here, this is characteristic. This is a 3D picture of scattered, and this is a 3D picture of a vascular endometrioma where you see all around, but nothing inside. So based on this, the RAFS stages endometriosis into mild, moderate, severe, and extreme. And this staging will help us make a score. So E1, E2, E3, E4 score by seeing where the endometriosis nodule is and how it is felt. And E4A, B, C, they are all, now this is all theoretical, it can be found in any textbook or any internet thing, and you all can just study it. But this is very important because the E scoring and then the F scoring and the urethral infiltration is very, very important for us to understand. For infertility, we do a revised REFS scoring, the American Fertility Society, and this will make a chart and predict the prognosis of the treatment. So previously it was mild, moderate, severe. Now it is that you should score it by REFS so that you can predict the success of the treatment. So how to go about it? You must know the symptoms. You'll do a good clinical examination, including a PS and a PV, a good sonography for looking at the pattern recognition of the lesions, and we'll come to all that just now. MRI if required, but not required in all. And of course, endoscopy, depending on the symptoms, and will be the gold standard. The clinician's catch-22 situation is that the history could be misleading. And very less clinical examination sometimes produces. Staging involves extensive investigation and laparoscopy still, because these type of lesions, nodules here and there, and sometimes with even marked adhesions, the patient is asymptomatic. So operative staging finally will be required, and everything will be required to complete it. So we need to answer some questions before we go on to ultrasound. Is staging necessary before surgery? Yes, to predict fertility. How do we take us and to be prepared for the operative procedure? How do we take associated extrapelvic into included? How do we include malignancies? Let's be optimistic. A better, simple, accurate staging and documentation is what is required. So there came IDEA. Now, IDEA is International Deep Endometriosis Analysis Group. And this is the group with the names. And they have a 15-page document which has been published and which you can easily access through Google and read and go through it. And this was in 2016 where they did a EMOS and an AMOS scoring. And let's go by it. So first is endometrioma. We know how it is caused, the shedding, it's pseudocyst, it is classical ground glass, it's more on the left side, it could be multiseptated. And when you open the cyst, sometimes you can get a clear fluid and then the chocolate fluid comes, and a classical kissing ovary will be there. So Professor Michael Bajaka, who I salute, and I thank him very much for sharing some of his slides, and I acknowledge his work, original work on the staging. And this is what he said of deep intraperitoneal adenomyosis at the rectum. You get a classical ultrasound picture like a red Indian's hat. Thank you, Dr. Michael, for letting us use some of your slides. IDEA statement is a consensus statement. It is standardization of terminology, so all of us speak the same language. And it describes the ultrasound location, and especially in deep infiltrating anatomical locations, consensus modified from Chaperon's anatomical distribution of pelvic. So all this is there. So EMOS. EMOS is endometrioma sonography. Peritoneal disease with flimsy adhesions, endometriomas, and DIE. And EMOS will affect up to 5 to 10% of them. So EMOS affecting up to 45%, and in reproductive age, DIE or nodules in the rectovagina. And then you need to correctly do a site-specific diagnosis in defining so that we can make an optimal treatment and to map preoperatively the location. That is why. So here is the schematic drawing of the IDEA consensus on where the nodules are, and preoperative in the anterior compartment, in the posterior compartment, in front of the uterus and back of the uterus, and 10% of them are anterior, 90% of them are posterior, and then you make them into a score. So define the presence of these nodules by a speculum examination, by a PV examination. You slowly slide your finger till you feel the nodule on the posterior part and on the rectal wall. And then with the ultrasound, we do a push-pull scheme. So overall goal is that we need to map the lesion and see the severe. So by palpation, we can see hard nodules, sensitive tightness. By AMOS, if it is adenomyosis, hyperechoic areas in the uterus, endometriosis or EMOS, hypoechoic areas in the nodule or in the. We look directly for the nodules, tumor and tissue, change anatomy, or we look at the indirect signs of adhesions where reduced mobility, tenderness, distorted anatomy. So the sonographic item is classical TVS, routine evaluation of the uterus and adnexa is the first step. Then evaluation by TVS on the soft markers, step 2. Then assessment of the POD, step 3. And then the assessment for the DIE nodules and the posterior compartment, step 4. So classical 4 steps, classical look at the uterus and adnexa, look at the soft markers, look at the POD by sliding sign, and look at the nodules. So step 1. Oh, I'm sorry, this video is not working. But step 1 is the adnexal and the uterine look at them. So you look at the uterus, you look at the various signs, and you say it is AMOS, vertical striae, hypoechoic areas inside, lakes, and endometriotic spots. Or look at the single endometrioma, classical ground glass, with or without, we will just come to that later. So AMOS is adenomyosis. And then you use, when you look at the uterus, you look at the MUSA terminology. MUSA is morphological uterus sonographic assessment consensus opinion. We all know this. And if you don't, read this paper, and then you always study the uterus by the MUSA icon. And the AMOS is that you look at all the areas equidistant. If the posterior wall is more than, if the bridge is broken, if there are local lakes, the color Doppler and the striae. And that is classical adenomyosis pictures. And there might be many of them as the AMOS idea group has suggested diagrammatically, you can see all of them by ultrasound. So when you look at it, you will find it. So we just go ahead. So AMOS, lines, buds, islands. These are the 3 and by MUSA technology. So here are the buds, here are the lines, here are the islands which are occurring. Very simple to see in a uterus. Irregular uterus, anterior wall, posterior wall thickness is much more than the anterior wall. And then we turn the color on. And when you turn the color on in those island areas, because it's endometrium, it will be supplied by spiral artery. You see that the spiral artery blood flow, which was to the endometrium, is going into that area. So that will clinch your suspicion. And then when you have lakes, and if the lakes are nearer to the endometrium, here we were doing a hysteroscopy and we saw that one of the lake or one of the endometriotic cysts was protruding. It is in the myometrium, protruding in the endometrium. And when we cut it, we saw that the chocolate material came out. So cystic areas in the myometrium or the lakes or myometrial cyst is in AMOS. When we look at the endometriomas, so endometrioma imaging is very important and has to be done systematically abdominally, where you see single or multiple with ground glass appearance, and then you measure them, and then you look at their ultrasound features by the iota scoring, the benign scoring, and the pattern recognition, and you recognize it as the endometrioma. Remember, in case of TAS, decrease the gain to make the bladder anechoic, so your sound wave go much easier. And you can study all these videos. The ground glass, typical atypical endometriomas, kissing ovary sign, and sometimes a fallopian tube later would be involved. So classical ground glass, swashing positive, that means swash where the fluid goes, not solid, it is endometrioma. Typical endometrioma ground glass, atypical endometrioma where there is a solitary nodule. So then you will have to do the solitary nodule height and length, and again put it in the iota in the benign criteria, so that you say that this is benign and endometrioma and not a malignant one. So typical one is unilocular with ground glass. Atypical ones are not ground glass, some fluid levels, multilocular, retracted clots, papillary projection, calcified lesions, and atypical completely. And these could be classical, aclassical, atypical, looks solid. Here are nodules. So these need to be put into the IOTA classification. So to tell B1, B2 or benign or M1, M2, whether it's malignant or not, and an expert opinion should be taken. So endometrioma is very, very easy to pick up. And unilocular with acoustic streaming. Unilocular without acoustic streaming. Now, these are important because when you operate, you see them different. So when you operate, see, first clear fluid came here. I'll play it again for you. And then you got the chocolate. So this was acoustic streaming. See, first clear fluid, and then then the chocolate fluid. So this is how what you can predict in. So acoustic streaming cannot discriminate between endometriomas and atypical because there is some clear fluid which is there which causes, and that is the fluid level, the clear and the. So again, I'm showing you that how it, when it was like this preoperative, this is what comes in the operative part. So acoustic streaming in an endometrioma seems to depend on the content fluid. Liquid streaming, so first thin and then thick will come. If it is thick, there'll be no streaming. If it is, then we come to the kissing position of the ovary. Both the ovaries are kissing with omentum in between. Laparoscopically, it appears like this. It appears like this, kissing with the omentum seen here. And this needs to be cleared completely. The ovaries need to be separated. The cysts need to be dissected out, and all the adhesions have to be removed. That was step one. Step two is that you are looking for soft markers. So site-specific tenderness, when you push the probe, you'll get pain. And this pain will tell you that is a soft marker for it. Fixed ovaries, kissing sign. Flapping sail sign, when you see the flimsy adhesions with fluid all around, they flap like a sail. And then sometimes the fallopian tube is also filled up, and peritoneal cyst. So soft markers, ovarian mobility. So do the push and pull sign and see that the ovary is sliding over the uterus. And look at the white line. I'll be talking about this white line again in detail. So ovaries could be free, could be reduced, or could be fixed. And that will tell us the mobility. So here, perfect mobility was seen. Here, mobility is not seen. It is here, right ovary. Here, left ovary focused when you release. So it was just stuck, and the whole ovary and uterus were moving together when you were pushing with the probe. See again, here both the ovaries, when you push them, the uterus, both the ovaries with the endometrioma, with the omentum, they all move together with the kissing. So these are the soft signs. And then the fluid might be collected in the tube. So incomplete septa, then you know it is hydrosalpinx along with it. So that needs to be. So when you look at sometimes when we operated on this case, after sometimes came back with a cyst like this, we had taken out the ovary, hysterectomy. Now these are peritoneal, pseudo-peritoneal cysts which have occurred. And once peritoneal cyst occurs, or sometimes even for endometriomas not regressing, I go ahead and drain them sometimes, because if we are going to take them for IVF, then we need to drain them so that we don't waste time. And we put in a needle, drain everything, wash it with saline and antibiotic, and then inject some ascarol sclerosing agent so that they don't recur. So this is what an ultrasound guided procedure which you can do for endometriomas which are small and which patients have to be taken up for, and you don't want to do surgery or they recurrent. The third sign is the sliding sign. We showed you the sliding sign. It will tell you whether there are adhesions on it. So adhesion prevents, you push one hand from above and do a sliding sign with the TVS probe, and you see that everything slides on each other. There is no adhesions. It doesn't slide, all goes together. That means there are adhesions like this, and these needs to be cut, and the anatomy needs. And if it is free, even with endometrioma, the free ovary may sometimes do. So minimal endometriosis can still be there if there is a sliding sign. So sliding sign will tell you whether the POD is obliterated, partially obliterated, or I'm sorry, some of these videos are not working, but it's okay. Then we need, as I showed you, that white sliding line sign. And that is a uterine serosa, which slides over the rectum, RVS. And that will tell us whether there is a rectovaginal septum involvement or not. So this is the white line which we're looking, that is the rectum, and this should be sliding over this when you push and pull. So that will tell you rectovaginal. And if it is not, it is broken here, the white line is only till here. So this is interrupted white line, and this will not slide. So it tells you there is endometriosis at there. And this is completely broken, and this uterus is completely plastered over the rectum or the sigmoid and will not slide over it. And that is interrupted white line. So this is what you saw. We see it in POD when it is completely obliterated. Step 4 is the anterior and the posterior compartment nodules. The anterior bladder, you fill the bladder and look at the bladder and push and pull. And posterior, you look at the deep infiltrating endometriosis. So let's see the anterior compartment. Now, anterior compartment nodules can be here on the bladder or on the ureter also. So you need to trace a little bit of the ureter. So anterior compartment nodule here, the bladder is full and you see a very small nodule. And then you need to maneuver your TVS probe to look at the distal part of the ureter. And looking at the distal part of the ureter could cause kinking, running laterally across, and the pain. So the ureter you identify, you can see the ureteric jet, and then you follow it back like here. And this is the right side. And this is, it is crossing over the iliac vessels on the left side. So a little bit part of the ureter. And in the ureter, you might sometimes find calculus. At the vesico-ureteral junction, you might find other diseases which is causing hydronephrosis. And if it is endometriotic nodule, as you can see here, this will also cause hydronephrosis. So look at the kidney also. So ureter, 5 to 10% of women, ureteric emos, and you have to look at it. And you have to look at the, if you go in diagrammatic, look at inside the pelvis. This is how you locate and look at the ureter. So look at the ureters. Look at the ureters with the color Doppler on, so that all the hypoechoic areas, which are blood vessels, will be there shown. So look at vermiculation of the ureters and the peristalsis and the sign and the jet sign, which occurs in the uterus, in the bladder, when the ureteric jet comes. So ureter, part of ureter is very, very important study when you are doing a classification. That's how we do it in the dummies. That's how we train people to look at the ureter, and right, left, and that's how we do. So there is a learning curve to look at the ureters. Then comes the posterior compartment. We know that the posterior compartment is the white line of the vagina and the ureter with the rectovagina, and the nodules occur usually here. This is the posterior compartment. So most common site is the posterior vaginal fornix, anterior rectum, anterior sigmoid junction. And this can be when you do a PV examination, if you slide your finger towards the uterus, and if you slide your finger towards the rectum, you can feel these nodules, or the patient will feel pain. And that is diagnostic of this. And when you do a ultrasound, this is the kind of picture which Professor Bazaka has defined, very classic Bazaka's picture of a red Indian hat. This is the sigmoid or the rectal bowel. Do we need magnetic resonance imaging? Yes, sometimes we do. It's non-invasive, but not easily available everywhere. And if you are in doubt of smaller nodules, you can pick them up by MRI. But again, ultrasound, anything above 5 millimeters nodules can be picked up by ultrasound. MRI can be used for this. So the IDEA experts, after doing 2,500 scans, and when you want to be the IDEA scoring at least 40 examination you should be doing, and answering these questions, TBS findings with colonoscopy, cystoscopy is required, TBS finding with urology, TBS finding to the treatment. Again, we have documented all these in a few books which we have written over the time, including in Jeff Cott's latest edition, Jeff Cott's textbook of, and in the latest edition of our Foxy and the molecules and drugs books. So these books are available on Amazon, and the FAQs and endometriosis, ultrasound, everything is there. So feel free to read them and feel free to give me a feedback on how do you like them and how do you this thing. I bring you greetings from my city of Taj. Endometriosis is a complex, challenging disease. It's the Mona Lisa smile. Is she hiding pain, or is she really smiling? Or it is this painting of a woman doubled up with pelvic pain. Endometriosis is an enigma. Endometriosis is like a benign cancer. You have to think endometriosis and look for endometriosis if you need to diagnose in women. Thank you very, very much to AFOG for giving me this opportunity to be a part of this great workshop. Thank you very much, everyone. Have a great day. Have a corona-free year this year. And let's hope we can meet in physically. Thank you very much.